Yeah, good afternoon. I'm Dr. Alsayouf. I did my residency in Ohio State University, and I'm really happy to have some of my attendants here with us, joining us. Today, we're going to talk about neurometabolic finding and involuntary metabolism. I will step down because we're going to be looking at a lot of MRIs. Okay, we use more of ABC and MRI in our department, just to make sure we are all at the same page. So our ABC in the MRI is the first one. We consider every MRI in the neurometabolic disorder is abnormal until proven otherwise. Guilty until proven innocent. And the reason for that, we want every patient or every doctor to dig into the MRI looking for finding. As Dr. Muhammad Jan said a few minutes ago, it is really important to look at the MRI because it can give you a very big, huge indicator and direct you to the right diagnosis. Second, MRI is strange with its twist and turn. So if you find an abnormality, please rest if you must, but do not stop. And the reason for that, if you have one pathology, two pathology, look for more pathology. And to emphasize this more, I'm going to have to say it in different language, and excuse my accent. No say dikeniemi. This is in Spanish. Do not stop. Nicht zu stoppen in German. Do not stop. It's very important to keep looking for another pathology. Ne vous arrêtez pas, which is in French. Don't stop, please. And bochioch is in Chinese. Don't stop. Now, third, bias and prejudice are attitude to be kept in hand, not attitude to be avoided. What do I mean by that? If I have an EEG that shows the right posterior quadrant abnormality, please look at the right posterior quadrant abnormality, because you might find the abnormality and you can bypass it as if nothing there. And we deal with this all the time. To also emphasize the importance of looking at the MRI, if I don't look at the MRI, it is not real. Every single MRI, every single patient I see, I look at his MRI. And all the residents working with us, they know we look at every single MRI of the patient we see, and it is not uncommon we find abnormality. This has led to the innovation of MRI of Al-Mafraq Hospital. We'll talk about it in a few minutes. Now, males and females have equal brain, so this one here is wrong. And please stay safe in the MRI. You see, this is an incident in the MRI. I really can't tell you what can you do about this, but make sure you have your bed belt on in case you need to fly. The MRI oath at the Mafraq Hospital, most of our residents know that. They have to do the oath. There's no other way around it. It is, I swear to God, I will look at every patient's MRI, the whole MRI, and nothing but the MRI. Again, to emphasize, you really need to look at your MRI. That's a very important slide. This is very important slide. Can you hear me? Can you hear me now? Okay. This is a very important slide. Myelin departure is represented by low signal in two weighted images. As you see here, this is an adult T2 weighted images, the myelin look black, and this is the adult brain, and it looks white on T1 weighted images, you see here. So this is an adult brain, T2, black is white matter, lighter is gray matter, the opposite on T1. The opposite of that, to confuse you more, if you look at the white matter here, it is, if you look at the white matter area here, it is white because there's no myelin right after a newborn baby. And in T1 here, in T2 here, in T1 here, you see it's black and there's some myelination here. And going through stages from newborn until adult, we can tell if there is a delayed myelination, a proper myelination, or demyelination. Myelination is central to peripheral, caudal to rostral, dorsal to ventral. This is the general rule. Now look at this MRI. This is a 1-year-old boy. We just saw him last week, and we looked at the MRI. one of Dr. Dina showed us the MRI. And you see, it is a delayed myelination because you should have more myelin, the anterior capsule and the posterior capsule should be myelinated. You should see more darkness here. So there's delayed myelination. There's generalized brain atrophy, and then I told them, this is delayed myelination, general brain atrophy. But if you don't do nivusamity, you're going to miss that. And this was the main problem why this patient was paralyzed on the right side and was not moving. And the rest of the main significant finding, we found one more of an incidental finding. And this is the T1 weighted image. Now I find this, myelination table is really very helpful. In the first year here, I only look at T1 for myelination. For example, at 6 months, the corpus callosum has to be myelinated. At 4 months, the cerebellum has to be myelinated. And here, brain achieved adult appearance in T1 by 1 year of age. In the second year of age, I would use more the T2 here because it always lags behind to assist the myelination. Now, let's talk about some terminology we're going to use in the lecture. This is T2. This is more of a terminal zone after you finish your myelination. There will be a white spot. This is called terminal zone. Here, what we call is, what do you call this one here? U-fiber. Keep it in mind because we're gonna talk about this a lot. And this is the deep gray matter, and this is the superficial gray matter. I want you to, this is the caudate nucleus. Putamen, the globus pallidus is here. Putamen, globus pallidus, posterior internal capsule, anterior internal capsule, thalami, and of course this is the lateral nucleus. Now this is an MRI of a newborn. You see the Mickey Mouse. This is the cerebral peduncle. It is myelinated because in T1 it looks whiter. And if you go up, you see the posterior capsule is also, posterior limb of internal capsule is also myelinated. That will tell us this is more of a normal brain MRI. And if you go up further, you will see the Rolandic area also has a touch of myelination. So this is a typically normal MRI of the newborn. If I don't see the posterior limb of the internal capsule myelinated at birth, I would really follow this kid closely because he might have a big problem down the road. This is a busy slide. I really apologize for that. But looking at the MRI and looking at the neurometabolic disorder is really very complicated. There is so many classification and there is so many inborn error of metabolism with a lot of abnormality in the MRI. That is a lot of the time it's overlapped, so you cannot separate it. But I picked up this algorithm because it gives you more of a pattern recognition in your busy daily practice. I look at the MRI, I use this algorithm, and it will help me big time to know my differential diagnosis. This is more of white matter demyelination or dysmyelination. The T2, the white matter in T2 will be hyper, the signal will be high, and T1 will be low. Here, hypomyelination, if you look at the MRI of a 6-month-old kid, his myelination is more of a 2 months old, or he has like a little decreased signal on T1 and blurring of the margin between the white matter and the gray matter, and I will show you in a minute. Now I decide this kid has more of a leukodystrophy, it's a kind of demyelination, dysmyelination. Then I would go this route. I would look, is it confluent? And if it is confluent, or is it multifocal? If it is confluent, is it supratentorial, frontal predominant, periventricular? Is it diffuse cerebral? Is it subcortical predominance, or parieto-occipital, or is it posterior fossa? This is supratentorial, above the cerebellum, and we go down here to posterior fossa, cerebellum, and cerebral peduncle, brain stem. That makes your life much easier. We are talking here about dysmyelination or demyelination. If it is hypomyelination, and then I'm going to show you guys examples. You see with no typical peripheral nervous system involvement. This is the list. With typical peripheral nervous system involvement, this is the list. I know it's busy. We'll go through it one by one. By the end of the lecture, if you keep in mind metachromatic leukodystrophy will give you periventricular, symmetrical, diffuse white matter abnormality. Adrenoleukodystrophy in a typical pattern, parieto-occipital, Canavan disease, symmetrical bilateral involving the U fiber we talked about earlier, and the Alexander disease due to frontal predominance. That's probably would be, I think I would be doing a great job. Now, here, this is what I meant. This is, if you look at the signal here in T1, the white matter is really bright, very bright. And this is in T2. In T1, it is hypodense. This is more likely R number 1, demyelination, demyelination, and not hypomyelination. The hypomyelination, you look here, you know, there is not, this is like 2 years age, there is not full myelination. This all area should be black. This is not full, it's more dirty. And you look at T1, it looks more normal, but it is lagging behind. More of like, you know, 6 or 7 months of old demyelination. That is what we call hypomyelination. Then we'll go through route number 2. Okay, now MRI characteristic, we decided the kid to have dysmyelination, demyelination, and it's a frontal predominance. And these are the disorders where you can have frontal predominance, leukodystrophy. We're going to talk about Alexander disease. Alexander disease is an autosomal dominant disorder. It is caused by fibrinoid leukodystrophy, or fibrinoid is caused by gene mutation of GFAP. There is 5 criteria to diagnose Alexander disease. If you guys look down here, which is 99% of the time we don't do, is the contrast. In the evaluation of leukodystrophy, we almost never do contrast. But if you see how important it is to do contrast, we would add contrast in every patient with leukodystrophy. Okay, there are 5 criteria in MRI to diagnose Alexander disease, according to Van der Knaap. Extensive cerebral white matter with a frontal predominance. If you compare this area here, in comparison to this area here, it's more predominant. Even though it's subtle, but definitely more predominant. That criteria number 1. Periventricular rim with high signal on T1, as you guys see here. High signal in T1. And what is the area involved here? The peritrigonal area is the optic radiation area. So it is high on T1, it is low in T2, that's the criteria number 2. If you have a periventricular, if you have a signal abnormality with a swollen or voluminous in the basal ganglia and the thalamus, look at the caudate nucleus here, it is so wide, you know, you cannot even separate it from the lateral ventricle CSF signal. So that's criteria number 3. Brain stem signal abnormality, as you guys see here, look at the red nucleus, beautiful, but abnormal, unfortunately. And contrast enhancement of one of the more of the following, one or more of the following, either the brain stem, you see the enhancement here, or enhancement of the periventricular area. If you find 4 out of 5, you almost got your diagnosis without doing the genetic testing. Now we are still in the dysmyelination, demyelination, and we decided it's a confluent. We went to the periventricular predominance, and this is the disorder that causes periventricular predominance. And we're going to talk about metachromatic leukodystrophy and the Krabbe disease. Krabbe disease is an autosomal recessive disorder, lysosomal disorder. It affects the central and the peripheral nervous system. It is dysmyelination or demyelination. This is why it should be hypointense on T1, hyperintense in T2. You see here, the deep cerebellar nuclei will be involved early in the disease, and it gives you also periventricular predominance. And one thing here, what is this structure here? Optic chiasm, hypertrophied, and if you look at the optic nerve here, is also hypertrophied. This can also be seen in Krabbe disease. If you find this finding, you should be thinking about Krabbe disease. And remember here, the subcortical U fibers are spared until late in the Krabbe disease. Metachromatic leukodystrophy, I think this is the diagnosis we think most of it when we see patient. It is a lysosomal storage disease caused by decreased activity of alpha-sulfatase A less than 10% of normal. It is an autosomal recessive. Assay of alpha-sulfatase A sometimes might not give you the answer, though you have to definitely do one of these other two testing, either the molecular testing or urine excretion of sulfatides. There is a three-form, late infantile, juvenile, or adult. And the subcortical U fiber are spared until late in the disease. If you guys look here, the white matter in the periventricular area is involved, and it is symmetrically involved around the lateral ventricle, and that's typical of metachromatic leukodystrophy. Now we are going to go to the parieto-occipital area. It's a confluent, it is dysmyelination. We went down to parieto-occipital area, and we're going to talk about the prototype that caused such abnormality as X-linked adrenoleukodystrophy. It's a paroxysmal disorder affecting the central nervous system and adrenal cortex. There's three forms: childhood onset, the most common form, Addison disease only, or adrenomyeloneuropathy. If you have an adolescent or even a young adult who start to have spastic paraparesis, please do me a favor, do yourself a favor, do the patient a favor, and get very long chain fatty acid, because this is might be one of the progressive disorders. If you look at the MRI here, there is signal abnormality involving the cortical spinal tract, and if we keep going up, look at the parieto-occipital area is heavily involved. At this cut, you cannot tell the CSF from the white matter, which is very typical for leukodystrophy secondary to dysmyelination or demyelination, not for hypomyelination. This is most likely consistent with adrenoleukodystrophy. And this is the same cut. Look at the cut here, more anterior. This is a coronal T2 section. Almost there is nothing. If you go back, look how extensive is the abnormality. That is very typical of adrenoleukodystrophy. Now we are still in this arm, in the confluent dysmyelination, supratentorial area, and we're going to talk about the subcortical predominance. And in the subcortical predominance, we're going to talk about Kearns-Sayre syndrome and Canavan disease. Canavan disease is an autosomal recessive. This is probably the prototype disorder that the U fibers are involved in. If you see this picture here, please think about Canavan disease. There's other differential, but please think about Canavan disease. You see the subcortical U fibers here are really involved, diffuse, symmetrical, bilateral involvement of the white matter that is involving the U fibers. And also, if you also look here, it involves the globus pallidi. That's very typical of Canavan disease. If you have a patient and you do an MRI and the MRI looks like this, you can just go ahead and do target testing for Canavan instead of doing like 10,000 dirham, multiple thousand dirham investigation. Here also, if you look at the MR spectroscopy, the N-acetyl aspartate, this is the normal, but look here, it is really peaked. This is also typical for Canavan disease, and thought at time it is pathognomic, but it tends to be more for ML. It can happen with Pelagius, Merzbacher, and Sala disease. Now we're going to talk about Kearns-Sayre syndrome. It's a triad, progressive external ophthalmoplegia, which is usually typical. You have typical retinal pigmental degeneration, salt and pepper, and dark blood. So clinically, this will direct you to Kearns-Sayre syndrome. And if it is a sporadic, it's a mitochondrial disorder. If you do muscle biopsy, you will see the ragged red fibers. As you guys see here, this is typical look of ragged red fiber. And if you look at the MRI, the subcortical white matter is very involved. Look here, but look at the deep white matter is almost spare. This is very typical of current syndrome. If you see this one, you probably made your diagnosis. Now we are going to talk about diffuse cerebral, a confluent demyelination or demyelination disorder. And the prototype probably in this category is MLC, megalencephalic leukoencephalopathy with subcortical cyst. If you see it once, you probably can diagnose it right away next time. Childhood ataxia with simple hypomyelination, or what we call vanishing white matter disease. Okay, MLC, as you guys see, it is an autosomal recessive. It is secondary to MLC1 mutation. The MRI is characterized by diffuse, abnormal, and mild swollen cerebral white matter. Look here. This is not a typical look for the white matter. Look also here. That is more of a very bright look of white matter. But if you look deep, you will see the subcortical cyst. This is a very typical, extremely typical of MLC. And there's also another disorder that can cause that on MRI. Anyone knows? One of them cofactor. And what is the third differential on this also? Severe hypoxic ischemic encephalopathy. Can give you a molybdenum cofactor, and MLC and the severe hypoxic ischemic encephalopathy can cause the similar look. These are the cysts. Now, vanishing white matter disease. If I cover the name here and I tell you, look at this, guys. What do you think this is the abnormality or the leukodystrophy? Canavan disease. Typical look like Canavan disease. So it does look like Canavan disease, but it is also autosomal recessive. It has ataxia, spasticity, and variable optic atrophy. If you guys look here, this is the optic nerve. Usually, if you want to look for optic atrophy, you usually have to do ophthalmological examination, but on coronal cut, you can see the optic nerve much better. Subcortical involvement occurs during early stages of the disease, just like Canavan disease. You see the U fibers or the subcortical area are involved. And also, very characteristic dorsal pons hyperintensity seen at the beginning, as you guys see here. It just shifted a little bit down. You see these two dots here. This is dorsal pons, hyperintensity, and this is why I said if you want to look at the MRI in a neurometabolic disorder patient, look once, twice, and up to 10 times, because you can miss this big time easy if you don't look carefully for that. And the diagnosis is basically based on you can do a genetic testing to confirm for that. Now we're going to shift gear. We just finished the supratentorial area. We're going to talk about the infratentorial area here. And we're going to go ahead and start on diseases that involve the cerebellum and middle cerebellar peduncle. And the prototype, I think, is cerebrotendinosus xanthomatosis. This is an autosomal recessive disorder. It is a lipid storage disease characterized by infantile onset, diarrhea, childhood onset cataract, adolescent to young adult onset tendon xanthoma. This is the genetic testing you can do for this if you suspect it. But the typical MRI finding, remember, we said now we are talking about demyelination, dysmyelination. It is infratentorial. So the cerebellum is more involved than the supratentorial area. Look here, the white matter abnormality. And one characteristic finding also, hypointensity in the cerebellar nucleus. That's very typical of cerebrotendinosus xanthomatosis. What's the blood testing we can do for that, screen for that? I think there's a fancy dandy name. I remember. Cholesterol. You can ask for cholesterol and the blood and see it will be raised. And you see this is all the abnormality we talked about. Now we're going to talk about the infratentorial confluent demyelination that involve the brainstem mainly. And the real prototype is Leigh syndrome. I just recently, 2 months ago, had a patient with typical finding of Leigh syndrome. Leigh syndrome is a mitochondrial disorder, so you expect to see the ragged fibers, as we showed you guys earlier. Most of children are normal at birth, but when they grow up, they have troubles. There's stringent diagnostic criteria for Lee syndrome by Rahman et al. Done 1996. And these things, progressive neurological disease, all the neurodegenerative disorder will have this. Sign and symptom of brain stem and basal ganglia. It's not uncommon for the other disease to have these findings. Raised lactate concentration either in the blood or in the CSF. 4. Typical finding in neurology or neuropathology or typical neuropathology and similar activity symptoms. What we care about here, neuroradiology. So look here, this is what's this structure, the vitamin, very affected. The globus pallidi are not affected. You see here, the midbrain is affected. So the typical findings, symmetrical bilateral involvement of the basal ganglia, as well as the dorsal midbrain or brainstem. If you do the MR spectroscopy, you can see the double peak here of lactate, and this will give you a hint that this is most likely a mitochondrial disorder. This is the abnormality disorder. Now let's talk about the hypomyelination or hypomyelinative disorder. We're going to talk. This is the one that does not come with typical peripheral neuropathy involvement, and we're going to talk about Pelizaeus-Merzbacher disease. Remember, these on T1 there will be bleeding of the gray-white matter, and in T2 there will be more of mild signal intensity increase. So you have to look at the T1 to help you to differentiate. Pelizaeus-Merzbacher disease, it is X-linked recessive. PLP1 gene mutation is the cause, and the abnormal, the MRI will show abnormal high signal intensity in the T2. Look here, it's abnormal high signal intensity. If I tell you this is full tear, is this a normal MRI for full tear bone? Even a full tear, it is not normal. Because remember, the posterior limb of the internal capsule is not myelinated, and it should be myelinated by birth. If I tell you this is 34 weeks, 36 weeks, you might say, yeah, it is, yeah, it can be. But look at T1. Remember, on there is no hyperdensity. There is complete blurring between the gray matter and the white matter. And if you look here, there might be a hint of increased signal of the T1 signal, which is very typical for hypomyelinative disorder. Guys, this, if you look at the T1 and T2, believe me, this will help you big time to direct your workout. Now, now we're going to go to the disorder that does have typical peripheral nervous system involvement, and I'm going to talk about hypomyelination with congenital cataract. I just saw a kid last week. I think he had this disorder by another description of the MRI. It is autosomal recessive, high C membrane protein abnormality. This is the gene. I know I don't know how to pronounce it, but if you look at the MRI, there is T2 signal abnormality involving the white matter bilaterally, periventricular. And look at the T1. Look how helpful the T1. There is blurring of the gray-white matter junction. So we are talking by definition about the hypomyelinative disorder. So we should start the workup for the hypomyelinative disorder. And this is the finding. Now, who would say this MRI is for the same patient, and who would say this MRI is for a different patient? And if they are different patients, are they one patient, two patients, 3 patients, 4 patients, or who cares? Is it for the same patient?
Yes.
Can you raise your hand? Who would raise his hand for the same patient? Okay. Is it for a different patient? By different okay. Who would say this is for 3 patients? The person. 3 patients? Okay. This is actually for 2 patients. The first MRI here, just Dr. Hamza showed the similar case, but it is not for the same diagnosis. This is a non-MRI finding in non-syndromatic mitochondrial disorders. And for me, it looks really similar to this one and this one. But this one and this one, Dr. Muhammad just talked about them. This is the latest publication about the biotin responsive basal ganglionic disease, and this is the way it looks. If I see this MRI now, at least for me, I would take either of these two differential diagnoses, and they will save a lot of money. Now this is a 35 leukodystrophy hydromagnetic disorder. This is more a business plan for those who want to know all the names. And this is, how you can triage them based on the age. And this is some of the tests you can do on leukodystrophy. And I think we're done.